the first thing they tell me is that for a woman with a BRCA mutation, either in their tumor, either germline or somatic, with an ovarian cancer, that PARP inhibition clearly has a lot of activity. And certainly for women with advanced ovarian cancer, I think this is something that we can't miss, that we have to be thinking about this, and that we have to be thinking about giving these women PARP inhibitors. Certainly, we have women who are already in the sort of post first line treatment setting, and if we know they have a BRCA mutation now, they've never had a PARP inhibitor before, we really have to think about PARP inhibitors as part of their therapy as we move forward. For women with newly diagnosed disease, we have to think about BRCA mutation testing, both germline and somatic, and then think about giving them maintenance PARP inhibitors. Beyond BRCA mutations, it is a very messy world. And I think that, the thing that we have struggled with as a community is that BRCA mutations remain the strongest biomarker we have of PARP inhibitor activity. And we know that there are other genes and other proteins that clearly have important roles in homologous recombination repair. And so that hypothetically, they might also be biomarkers of a good response to PARP inhibitors, but it's been hard to define them. Our assays of homologous recombination deficiency, or HRD, are really imperfect assays. They're all approximations that are guessing at the actual HR status of a cell without being able to directly measure it. So they're using sort of patterns of change that are scarring patterns, but don't have the ability to change as the cell itself changes. So they don't have that dynamic quality. And we've found, I think, that if you look at all of our studies, that HRD testing can give you potentially some information about whether a patient might have more or less benefit from a PARP inhibitor, but it's not able to rule out that somebody is going to benefit from a PARP inhibitor. And so in that setting, I think that there's a lot more there's a lot more work that we have to do. We also haven't shown in that setting that doing maintenance PARP inhibitors helps women live longer. And so a lot of our discussions, I think, have to be together with our patients. What is the benefit of doing a PARP inhibitor in terms of extending progression-free survival? Maybe we will have additional data about overall survival benefit, which would be fantastic to have. Also weighed against the price of taking a pill that is much better than chemotherapy but does have side effects, and taking it for an extended period of time, perhaps 2 or 3 years in the frontline setting, and indefinitely in the recurrent setting.